that would be great, so I can see you. If you can't, for whatever reason, that's fine as well. If anybody has any questions or observations while I'm talking, please feel free to put that in the notes, in the chat. Otherwise, and then I can come to that once I've done my presentation, and we'll have a bit of a time, hopefully, for questions at the end. So I'm going to share my slides with you. Okay, so hopefully everyone can see my slides. If not, perhaps somebody could just let me know. I hope you can see that. So I'm Ruth Anderson, and I'm a counselling psychologist working in the Red Cell Haematology Psychology Service at UCLH. And I'm going to be talking to everybody today about psychological well-being and psychological support in thalassaemia. And so just to give an overview of the areas that I'm covering today, I'm going to talk about some of the key challenges in thalassaemia, which I'm sure a lot of you will be very well aware of. I'm going to talk about thalassaemia and psychological distress, the role of psychological support. I'm going to talk about a few different cases. I'm then going to talk about the role of patient as teacher and how important that is, both for me as a psychologist and for all of us as healthcare professionals. I'm going to suggest some possible ways of strengthening the therapeutic relationship, and then I'll give a brief overview of what we offer at UCH, and then there'll be an opportunity for questions at the end. So, of course, a number of different challenges come along with ill health. And there's a diagram here which tries to show some of the key different areas in terms of challenges that people with thalassaemia might experience. So in the light blue there, of course, there's the physical health aspect. So the different health issues that somebody might have as a result of their condition and treatment. The physical incapacity and pain that they might experience, the fatigue that they might experience, and of course that these needs are ongoing, that it's a lifelong condition, it's something that is often progressive and requires further treatment and intervention as life goes on. And of course, there are a lot of demanding and complex treatments that can have side effects. There's something that people have to keep taking or have to keep coming in for their transfusions, and they're a reminder of the condition and of perhaps difference between somebody and somebody else. And then in the green boxes there's something around living with uncertainty and lack of predictability, the need for a lot of adaptation, and that might have to keep happening as somebody gets older and might perhaps develop more complications from their condition. And then in the yellow boxes, there are some things about the relational impact of having this condition. So the changes it might mean to roles and relationships, to what somebody can do within their household, how that might change within time, about changes in perceptions of others. There might be some stigma or discrimination that people experience that might lead them to want to withdraw, to want to isolate from others. And of course, there are employment and financial consequences as well, in terms of whether somebody can continue to work, whether they can continue to do a role that they were doing previously. And so for many people with thalassemia, of course, they might experience psychological distress, they might experience uncomfortable feelings. Could be all kinds of feelings that somebody might have, and they might have different feelings at different points. It would be common to feel anxiety, fear, perhaps anger. There could be some sense of hopelessness or sadness or grief. And as with anyone, there are different ways of coping, different ways that we all have of coping to manage difficult feelings. So, just to talk a bit about some of the ways of coping with serious illness, with living with a lifelong condition. So, some people might find it helpful to normalize, so to acknowledge their symptoms, but to normalize them in order to reduce the worry and to neutralize the threat that they feel is posed by them. For other people, there might be some level of denial, so denying the existence of symptoms or of their illness or the threat that this illness might pose. And in the short term, this could be beneficial because it could help somebody to perhaps get on with things that they feel are important to them, or to come to terms with their condition more gradually. But over the longer term, this could pose some difficulties in terms of people who might not be adhering perhaps to the treatment that they need. And so it might increase their physical difficulties. For some people, there might be some avoidance. So people might want um, to sort of avoid potential triggers and to perhaps limit what they do in their lives, which might affect their quality of life. So they might be so fearful of getting ill or getting worse that they might restrict what they do and therefore not really allow themselves to live as fully as they might have done. And then another thing is this kind of resignation. So somebody might become very preoccupied with their illness and see it as the key part of their lives. There might be a sense of hopelessness or a sense of helplessness, and that in turn can increase somebody's physical incapacity, where somebody might be perhaps feel very dependent on others for their care and perhaps not do as much as they might be able to do. And then people can get to a place of accommodation, of acknowledging and responding and actively managing their symptoms, illness and treatment, thereby limiting as much as possible the impact that it has on their lives. So that's something about perhaps a degree of reconciliation to the situation and trying to maintain as much normalcy as possible by focusing on other important aspects of their lives and of their identity. And this is something that sometimes in psychology we could work with somebody to try and get to some kind of place of accommodation. So understandably, people with thalassemia and their caregivers are faced with different psychological and social challenges, which may result in them experiencing anxiety and depression. And that depression or anxiety is associated then with increased distress and pain intensity. And so psychological support can be important at any point along the lifespan of somebody with thalassemia. So as this quote here from the 2021 guidelines for the management of thalassemia state, these social and emotional concerns can occur anywhere along the lifespan, and these concerns can have an impact on the patient's quality of life and physical health. And so therefore, there should ideally be an opportunity there for them to have some psychological support. So in terms of psychological support, in terms of talking therapy, in terms of what it might offer somebody. It can be an opportunity to validate and clarify their experience. It can be a place where they feel safe to access and express feelings, and some of those feelings might be difficult feelings that they don't particularly want to share with family and friends, or that family and friends don't want to hear from them. There might be recognizing and validating different parts of themselves or different parts of their experience. So it might be around talking about a sense of vulnerability, and alongside that, a real sense of strength and resilience. And we would really want to look to building on people's strengths and on their internal resources, and also the resources that they have around them that they can draw on. And then the idea of accommodation that I just touched on, in terms of getting to a place of living with a condition, and also turning the spotlight onto other parts of their lives and other interests that they have as well. So we would hope to increase people's coping and self-management strategies. With that might come increased adherence to their treatment, might mean less pain medication is needed. If they're feeling better in themselves psychologically, and therefore that has a knock-on effect physically, it might reduce their frequency of hospital admissions. And if they have a space where they feel free to talk about what's happening for them, it might reduce a level of tension and conflict and improve communication within health services more generally. So I wanted to take the opportunity to talk about a couple of cases, a couple of people with thalassemia that have sought out psychological support. And I've changed some details. I've obviously changed the person's name to ensure that they're anonymous. So the first thing I wanted to talk about is something around stigma and discrimination. So where I explored with somebody their experience of living with stigma and discrimination. And just to kind of look at those two terms, so stigma relates to the devaluation of somebody, and then discrimination is unfair or unjust treatment of somebody that can be due to that stigma that they experience. So I'm going to talk about somebody in their 30s, somebody with transfusion dependent thalassemia. I'm going to call her Amira. And so this is somebody that is attending their transfusions and that's regularly taking her chelation therapy. And one of the issues that we've been exploring is her experience of stigma and discrimination within her community. So we've talked about a marriage proposal that they had that broke down in the past because her partner's family did not want them to marry somebody with thalassemia. And we spent a lot of time talking about her feelings of hurt and anger that the family didn't come to her directly to ask about her experience of living with thalassemia and how it affected her on an individual level. And instead, they did their own research behind the scenes, as it were, and then told her parents that the marriage could not go ahead. So we focused on that and on the ongoing sense of distress that she experienced in relation to that. And we also spoke about her experience of living with thalassemia and how proud she was of how she was able to manage her condition, how proud she was that she was adhering with her treatment, that she was in reasonable health. She was able to work full time in a really enjoyable, interesting job, and to help to support her family. And we spoke about how her experience with her fiance had really given her a sense of being unwanted and of little value, and feeling in some way tainted. And we reflected on how these feelings resulted in her sometimes putting other people's needs above her own. While she was adhering to her treatment, she might not always prioritize her own well-being and might not get as much sleep, or perhaps eat the right kind of foods. So part of our work together was considering how she might put herself first. She recognized that she did value herself. So we worked on increasing that sense of her being valuable, of somebody to be prized, somebody that would make a good partner. So that's the first case study. And so the second person I want to talk about is somebody that I work with who wasn't currently adhering to their chelation therapy. And of course, adherence to chelation therapy is the single most important action that can improve somebody's long-term health and long-term outcome. And yet it can be very hard for people to adhere to it. And quite a few people are referred to get psychological support in order for this issue to be more fully explored. So again, I've changed some of the details and changed the person's name here. So this is somebody in their 30s with transfusion-dependent thalassaemia. I'll call her Zainab, and she attended her transfusions but did not regularly take her chelation therapy, and as a result had quite a lot of iron overload. So as part of our work together, we talked about her childhood experience of living with her condition, the way in which she could, I guess, avoid or sideline her condition when she was a child, as her experience was that her parents took care of everything for her as best they could, and she was encouraged to lead as normal life as possible. And in terms of her experience of the healthcare system, she said that her experience at her current hospital had been very good, but she had had some bad experiences at a previous hospital where she did not feel listened to and did not think that the healthcare team was acting in her best interests. And also spoke about the grueling nature of her treatment regime. It used to be that chelation wasn't available in tablet form, and so it was very, very grueling and quite a torturous process at times. And as an adult, Zainab described the amount of admin time that it took to manage her condition, and said sometimes she just didn't want to do that, and she wanted to focus her time and energy on her challenging and enjoyable career and on her life outside the hospital. And so there was a bit of a kind of conflict going on in terms of her cognitively knowing rationally what she needed to do in order to maintain her physical health, but also a strong feeling of not wanting to comply with her treatment and almost wanting to rebel against it in some way. And so we explored her experience of getting off track with her medication and feeling very bad about this, of sometimes sort of avoiding what was going on rather than getting back on track. And we also spoke about the difference between transfusions and chelation for her, because transfusions seemed somehow more necessary and she could see an immediate effect from them in terms of alleviating her tiredness. But she felt that the chelation tablets were this kind of daily reminder or poke that she has a condition that won't go away, and she wouldn't feel, particularly better after taking them. She might experience side effects. And so she'd built up this kind of idea that she could somehow do without them. And we considered that was perhaps very understandable, but could be a dangerous game to play. And there was also the sense link to that really with the tablets, that even if she took them, her sense that, you know, it wasn't enough, the condition would remain, you know, it would get worse as she got older. So the condition itself being something that she felt, you know, can't be contained despite the treatment that she was taking. And we considered the way in which she was coping by being very self-sufficient, by not perhaps asking other people for help, even people close to her, in terms of helping her with her treatment or with how she was. So she'd developed a way of being very independent. And we considered whether she might consider, in some cases, allowing other people in a bit more. And again, moving towards that process of accommodation, of living with her condition, and perhaps moving away from some of the denial and avoidance that might have been going on. So I was going to move on to go beyond psychology, specifically to go beyond psychological support, just to talk about ways of working more generally, because of course, a psychologically informed model of care is not just for people who are really distressed. It's not just for a specialist practitioner. It's for everybody to try and think about or work with. I just wanted to pause before going on just to see if anybody at this point had any questions or observations to make.
Hello, could I make an observation, please?
Absolutely, please do.
Hiya, I'm Katie Stevenson from Manchester, and in the first case that you had, we had a very similar situation where the girl was going to marry a boy, and then the boy's family backed down, and it was a girl that had thalassaemia, and it turned out after years later that they didn't back down because the girl had thalassaemia. The backing down was because the boy's family had thalassaemia genes within their family. Although they didn't have anybody with thalassaemia major, they had quite a lot of carriers. So their thoughts were, well, the boy had a trait, and they didn't want to, because the chances would be higher that they'd have a child with thalassaemia major. And it didn't turn out. And initially, it was just, no, you've got thalassaemia. We don't want to marry. We don't want our family, to be associated with your family. But it turned out in the end that actually both families had thalassaemia genes, and that was the reason. But obviously, the girl was absolutely heartbroken at the time. And I think had she known the full story at the time, it would have actually made the situation a lot better.
Absolutely. Absolutely. Yeah, that's really interesting. So there was something else going on that she wasn't aware of, and that might have helped her to think about it all. And I guess, of course, that is something that it's something that people think about in terms of when they meet somebody, and something that can get checked out and that kind of thing. And then sometimes people have to make that difficult decision, even without family intervening, as to whether they do want to continue to be with somebody.
Mm-hmm.
It does make things very tricky sometimes. Thanks for that.
No, thank you.
Does anybody else have any questions or observations?
Hi, Ruth. It's Noemi here from Hematology in Oxford.
Hi there.
Thank you so much so far. It really resonates, and especially for me, especially the second one about this patient kind of convincing herself that she doesn't need the chelation. And I think that sometimes as busy clinicians, we can give the impression that I don't know how to say this in a politically correct way, but that they're stupid to think that, right? And yet from the psychological point of view, it's not stupidity. It's a very complex coping mechanism. And I'm wondering what advice you can give to us who, we're seeing the patients like this, and, what can we say, apart from saying, I'll get you a 1-hour appointment with a psychologist, which may not be around the corner, but what can we do to to acknowledge to the patient that we understand that it's complex and we don't think they're stupid, but that it is serious, that something needs to be done. Do you see what I mean?
Absolutely. And I know, of course, that there are big time pressures. So you're not necessarily going to have a lot of time and space to sit with somebody and listen to their experience. But I mean, I guess if you do have a little bit of time, even to sort of open it up and ask them, what they find particularly challenging, just to come at it from that position of curiosity rather than that position of, oh, well, you need to do it and that's that. So to be curious and to be, oh, well, what's going on there can be helpful. Or
But
even
do patients just, will they say that to us, or does it take you, the psychologist, the gentle probing to get to the point where they admit that, yes, it's because they just don't like to think that they need it? Do you see what I mean?
Absolutely. I mean, of course, it depends on the individual, and some people may feel less comfortable, talking about things that are perhaps a bit more private to them. But other people might find it quite refreshing for somebody to sort of be curious and to sort of step a little bit away from the very sort of medical, well, you need it because of this.
Okay.
I think it might be a relief for some people, in terms of my experience of talking with people's experience of medical professionals, just to kind of have that opportunity to say, well, I have this particular concern, and it could be around side effects. I'm thinking about people I work with with sickle cell who might struggle with their hydroxyurea because of side effects of on nails or skin or hair, which, again, you could say, well, that's not important, but to that person it is. And if you're a young person, just kind of getting out there, that might be really have an impact. So I think having just a little bit of airspace to say some of these things can be really important. And then, if you get the sense that somebody really doesn't want to go there, then that's fine as well, isn't it? But
I guess, I mean, I won't take up all the time, but I guess maybe more it's the opposite. It's the worry that you're going to open a can of worms and you're going to be stuck there for an hour and you can't carry on and see the next patient. But maybe just showing that curiosity would be a start. Thank you.
Thanks for that. Does anybody else have any questions or thoughts at this point on the case studies or anything else?
I'm sorry, I feel like I'm hogging your time, but on the
No.
second one with the non-compliance, I've worked in both paediatrics and adult services, and I noticed that when I was in paediatrics, the parents to not completely take over the whole of the patient's care, and actually to be inclusive and actually give the child some onus and responsibility for the condition. When I've gone into adults, those are the patients that do really, really well, whereas the ones that are smothered in, wrapped in cotton wool, are the ones that really struggle in adolescence and adulthood. And we also have, rarely, a few parents who don't see the importance of the collation themselves. So therefore, that's passed on to the child, who also takes that into their own adult life. So sometimes I think it's the paediatrics that we should be focusing on, and the parents.
Absolutely. Sorry, Seth.
I said, I don't know what your views are on that.
Yeah, I absolutely agree with you on that. And I think that having that psychological support for the paediatric service as well is vitally important, as you say, in terms of supporting the child, but also supporting the parents and the family as a whole, because the attitudes that parents and family have towards the condition is going to profoundly impact on the person with the condition and how they then cope with it in adult life. And of course, there can be parents who could be described as being very protective, who, wrapping their kids in cotton wool, they're not really letting their kids have an opportunity to kind of really learn things for themselves. And then that can make things a bit more difficult in terms of somebody spreading their wings and really getting going on adult life and being independent. At the other end, there can be people who don't get a lot of interest or support from their parents, and so I guess, are left not really knowing what to do because of that as well. So I think, yeah, absolutely, it needs to start early on in terms of helping somebody to accommodate their condition.
Because on the side of the parents as well, some parents just feel so guilty, because they're carriers, so they don't have a problem, but then they've produced a child who has a disease that they know that, they've passed on to the child. So that burden of guilt sometimes affects the way they treat the child.
Absolutely, absolutely. And your in your experience, what might be the impact of that in terms of how they treat the child?
So it can go two ways, really.
Yeah.
So either they ignore the fact that the child has the disease, they miss hospital appointments, they don't give collation when it's, and they'll say, well, my child cried, so therefore I didn't think it was really necessary. I don't want to upset my child. So there's the ignoring part of it, but then there's also the, every time the child says, oh, and the parents are like, oh, is it the thalassaemia? Lots of trips to the GP that are perhaps unnecessary, and one way or the other, overprotective or underprotective in a way.
Absolutely, which echoes what I was saying around different parents' responses. And I guess sometimes parents might need helping to get more into that middle space, maybe, where of course they're concerned and interested and responsive, but not to the point that they are increasing the level of anxiety in their children.
I think they also is Grace here from Manchester as well. Sometimes they don't discuss with the children because they don't want to discuss. I have a patient that said when I spoke to her, she passed the phone to the mom, and I'm talking to the mom. And I said, "Can I speak to her?" And oh, we don't discuss about that. She doesn't want to discuss about that. So I on the phone you can't argue, and because that makes it that the young patient has never accepted it. For her, there's nothing wrong. Mom is protecting me. So that's the problem. I think, like Katie said, we need to also not always forget about the carers who are the parents, because they are the one to give us to give the way for them to accept this situation. If they don't accept it, they don't discuss about it at all. I have a couple of that.
Absolutely, absolutely. So a lot of it might be about what's going on in the family environment, about how the condition is talked about, whether it is talked about at all, or whether it's almost a taboo or hidden subject that isn't discussed, and what the child may then think about their condition, and going to that place of denial or avoidance, maybe, which I guess it's in one way helpful, but can't go on forever necessarily, and also will have an impact on how they engage with their treatment, perhaps, or how they live with the condition as they get older.
Sorry, and then there's the issue of, if it's an only child, then there isn't a problem. But when the child has siblings that are carriers, or they don't have thalassaemia major, it's how the family interacts with the children interact with their siblings, and how the parents interact and maybe treat the child with thalassaemia as if they're a little delicate rose. So family dynamics, it's not just about the patient and the parent, it's also about siblings as well, isn't it?
Absolutely, yeah, it is, and it's about different people's places within a family, and how they're seen, and what it might feel like to be seen as the delicate, vulnerable, fragile child. And I guess what the other siblings might think about that, because I know there can be feelings of envy, resentment, if one child's getting a lot of the attention, or that can be how it's perceived, that they're taking up a lot of the attention and time of the parents. So it's how the whole family is operating, really, and how helpful that is. Any other comments or questions? I'm very happy to keep talking amongst ourselves, as well as presenting a bit more on ways of working. Okay, so I'll move on to this part, which is more about that idea that psychology is for everyone. It's not you know, purely for psychologists or therapists to be offering some of this stuff. And I think often in a healthcare setting, there can be a risk of conflict and misunderstandings when the patient's feelings aren't acknowledged, and sometimes it can get into a bit of a position where a patient might be labelled as being difficult, rather than thinking that actually it's a difficult situation or there are difficult feelings that the patient might be experiencing. And by focusing on situation and feelings rather than the individual being difficult, as it were, perhaps we're more likely to find a solution and, you know, to be able to provide compassionate and respectful care. I guess that idea that people might need attention, they might need to talk about their feelings or about what's going on for them. It's key to identify what's going on. And I'm just thinking about the way in which sometimes people can get labelled in different ways because of the way that they're appearing, which can be very difficult to sit with, of course, and can particularly if there's somebody who's presenting as being angry, for example. And then just something I touched on earlier around the role of the patient as teacher, and I guess this sort of links in with what we were saying earlier about curiosity, about the idea that the person with the condition knows about their condition through their lived experience of it. So, you know, there's been research done on this. This is a quote from, I think, somebody with sickle cell, actually. So somebody who, you know, I know how to start my own IV, I know how to take my own blood pressure, I know what my counts are, I know these different terminologies from experience, and there's this like sense that people have to know in order to keep their health together, in order to get the care that they require when they do come into hospital. So I guess being curious about that particular person and their experience of living with their condition, and linked to that active listening, just you know, even if it within a short space of time, I know it can then open things up, but just to give somebody a little bit of space and a window to talk about what's going on for them, and then that can in turn help them to take more responsibility for their own health because they feel more in control of what's going on and feel more actively involved. And of course, you know, the importance of the therapeutic relationship and that collaborative and warm relationship between the person with the health condition and healthcare professionals, which of course can be extremely challenging in the acute healthcare setting where there isn't a great deal of time and space. And yet there are things, I think, that can be done in terms of getting that balance between being professional but also being human, in terms of, like we were saying, in terms of taking time and listening, having that respect, relating as equals, you know, two humans in the room, and that sense of empathy and compassion and genuineness as well, and somebody knowing that you know you're genuinely trying to help them. So that's pretty much the end of my presentation. So I work in the red cell hematology psychology service at UCH, and we currently offer mainly outpatient appointments to people, mainly one-to-one psychological therapy. We do work with couples, we do work with families, we also do a lot of consultation with other members of the red cell team, and can get involved in people's care plans. So as I was saying, getting involved in helping people to adhere to certain aspects of their treatment, And then if appropriate, there's quite a bit of liaison and referral to other services, because somebody may have other issues going on that would be better met by another specialist service, example, a bereavement service or something like that. So that's that. So I'm going to just come out of my presentation. And I've stopped sharing, haven't I? I think I've stopped sharing. So we've just got a few minutes left. If anybody did have any final questions or reflections, I think we've got about 5 or so minutes left. Just to check, everyone can still hear me.
Yeah,
If
we
someone
can.
could just confirm.
Yeah, we can hear
Just
you.
get this certain fear that the sound has gone completely. And no, that's good. I'm glad you can all hear me. Well, it's been, I hope this morning's been helpful and interesting. If anyone did have a final observation, please feel free.
So what I mean, I actually don't work in the hospital anymore, but what I did find useful was to know when the patients are coming in for transfusion and just go and spend 5 minutes with them. You know, how are you? How's life? You know, not just talking about the thalassaemia, but talking about, you know, the work, the education, you know, what's going on in the family, you know, weddings, anything like that, not just focusing on the thalassaemia. And that builds up a really good therapeutic relationship with the patient. And then, you know, actually having contact numbers for the patient so that the patients can ring you if there's a problem. And just, you know, just being there really.
Absolutely, and I think that's really important. I think that's really important as a psychologist as well. You know, the value in just being there. You know, the value in, you know, yeah, just being alongside somebody as well as sort of the content of what you're talking about. And there's something really important there about focusing on other aspects of people's lives, because people can sometimes feel that everything is related to their condition, and particularly if they have a whole bunch of hospital appointments all the time, it's sort of endless. And so to think, okay, it's great, I can talk about something else because I'm not just that, there's so many other aspects to my life. So that can be really refreshing. Right. Anything else, or are we okay?
I think
Right,
if we
well,
are done, a massive thank you, Ruth, for coming in and doing this. We will be putting this recording on the website, hopefully this afternoon. So anyone else who you think might benefit, please do spread the word. And yeah, really good session. And thanks everyone else that attended and joined in the discussion, because it made it really beneficial. So yeah, thanks again.
Thanks,
Thank you.
everybody. Nice to see you.
Bye.
Bye.
Thank you
Take
very
care.
much. Bye-bye.
Bye-bye now.